بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. يسعدني أن أكون جزء من هذا الفريق الذي يحضركم لامتحان SPLE وحظا موفق للجميع. For my part, I'm gonna focus on infectious diseases. So we can talk about infectious diseases for days and days. So I tried to summarize them to make it easier for you to see the most common type of infectious diseases. So the outlines for this presentation are to start with some key definitions which are gonna help you throughout the presentations. Then we will talk about the most common type of bacteria, followed by antibiotics, which I'm gonna talk about based on mechanism of action. Later on, we will move to the most common bacterial infectious diseases. After that, we're going to talk about antiviral, antifungal, and we will end it by talking about anti-tuberculosis medications. So, empirical therapy, what does that mean when I say I started the patient empirically on an antibiotic? That means when patient presents with an infection, most of the time it is a life-threatening infection, and I cannot wait until I identify the type of bacteria, which takes time. It takes usually at least 1 to 2 days, because I'm gonna draw culture from the patient, I'm gonna send it to the lab, and then the lab is gonna identify it, and then they're gonna get sensitivity. All of this gonna take time, and it's unethical to keep the patient without an antibiotic. So this is what we call by empirical therapy. It administering the antibiotic prior to documentation and identification of the offending organism. Most of the time I start the patient on a broad spectrum antibiotics, meaning I started the patient on an antibiotic that kills many different species of bacteria. For an example, if I start the patient on piperacillin, tazobactam, I guarantee that this type of antibiotic is gonna kill gram-positive, gram-negative, and anaerobes, because until this state, I don't know what type of bacteria this patient could have. Narrow-spectrum antibiotic, that means it kills only a few different species of bacteria. That means, for an example, it only kills gram-negative, which in this, I can use it if the bacteria has been identified, so I can narrow the antibiotic to that type of bacteria. And this is what I call by de-escalation. De-escalation means a change in the initially appropriate antibiotic therapy from an empirical broad spectrum characteristic to a narrow spectrum characteristic. For an example, if I started the patient on piperacillin tazobactam, and then the type of bacteria was only gram-negative, I can give an antibiotic that kills only gram-negative bacteria, like for an example, ceftriaxone. And we will go over these in much details. Another definition is the antimicrobial stewardship program, which is a program that has been started in many institutions. It is mainly aimed to optimize the use of antimicrobial agents. So it's to optimize the selection. So as I said, we are selecting the antibiotic based on the bacteria, especially if we have the bacteria identified. The dosing should be correct based on that program, and for an example, dosing patient who has meningitis is totally different from dosing patient who has abdominal infection. The route of administration, could the patient be changed from being on intravenous to PO or oral medication based on the GI tolerance, and the duration of therapy. All of these, if I optimize the selection, dosing, route, and duration of therapy, are gonna help to minimize a clinical cure or a prevention of infection while limiting the unintended consequences like emergence of resistant, adverse drug events, and cost. Unfortunately, some clinicians use antibiotic as a luxury. They're not luxury because they can cause bad consequences like, as I said, resistant, adverse events, and so on. The antibiogram is the result of a lab testing for sensitivity of an isolated bacteria strain to different antibiotics. As I said, we usually take culture from the patient, we send it to the lab, and then the lab identify the bacteria and sensitivity. So this is what we call by antibiogram. So this is, for an example, an institutional antibiogram. It looks at gram-negative bacteria and how many when isolated, and then it tested them against the available antibiotics. For example, here we have E. coli, and there are 204 isolates, and when tested against ampicillin, it was only 76% sensitive. So this will gonna help us to select the best antibiotic based on the institutional antibiogram, and it's usually done quarterly or biannually. Minimal inhibitory concentration, or MIC, means the lowest concentration of antibacterial agents which prevent visible growth of bacterium in 24 hours. So when I say MIC, I mean the prevention of visible growth. The minimal bactericidal concentration, or MBC, mean the lowest concentration of antibacterial agent required to kill a bacterial particle bacterium. So this is to kill, and while this to prevent. So this is different. When we look at the pharmacodynamics of the antibiotics, they are either concentration dependent or time dependent. So concentration dependent means the activity occurs where higher drug concentration are associated with a greater rate and extent of bacterial killings. Examples of concentration dependent are fluoroquinolones, aminoglycoside, and metronidazole. Time dependent, on the other hand, is maximized when these antimicrobial are dosed to maintain blood and or tissue concentration above the MIC in a time-dependent manner, and beta-lactams exhibit time-dependent activity. I'm gonna explain this more in the upcoming slides. So this is mainly, we said, aminoglycoside, fluoroquinolone, and daptomycin, colistin are all concentration dependent, and we are targeting here peak to MIC ratio, and it's preferred that the concentration is high so we can get the response faster. For time dependent, like beta-lactams, we like the antibiotic to be above MIC for a longer period of time to maximize the benefit of the antibiotic. For example, these time-dependent antibiotics usually require more frequent dosing, extended or continuous infusion. So sometimes we say bactericidal antibiotic and other type of antibiotics are bacteriostatic. Bactericidal, the word cidal means killing, so, and bacteria is the bacteria. So it kills the bacteria to reduce finally the bacterial load. Bacteriostatic, on the other hand, it inhibits the growth and reproduction of bacteria. In all cases, all antibiotics require the immune system to work properly. Bactericidal are best used in life-threatening infections or in patients with poor immunity. static require intact immune system, so they can be used in less life-threatening infections. So again, we finished with the definitions, and this is again telling you on how to identify the bacteria. We identify it by what we call gram staining. However, first we need culture and sensitivity testing. So first we take the specimen from the patient, and we usually start antibiotic before culture results are out, and this is what we called again by empirical therapy, because antibiotic can alter the bacteria in the specimen. And then later on we will identify the bacteria and sensitivity, we can change the antibiotic accordingly. So gram staining, it's a common technique used to differentiate two large groups of bacteria based on the different cell wall constituents. So basically we take the specimen and then we stain it, and this is what we call by gram stain. Gram stain procedure distinguishing between gram positive and gram negative groups by coloring these cells either red or violet. So we know that gram positive have thick cell wall, so they stain blue. Here I'm not gonna go over the procedure because it's more of microbiology rather than pharmacy. Gram negative, they have thin cell wall, so they stain pink, as we can see in the picture. So it's telling you this is a gram positive because it's stained blue, and this is gram negative because it stains pink. Here is an example of culture sensitivity and testing report, which is gonna show in the system. So here is the source is telling you it's from urine culture, and it's also showing you the MIC of the bacteria. The type of bacteria is E. coli, and then it's telling you S for susceptible, that means sensitive, and we can use this antibiotic. I for intermediate, so it could be either in between. R for resistant, so we try to avoid these antibiotics which are resistant. So we look here, and we have multiple antibiotics that are sensitive and other antibiotics that resistant. So we select the narrow spectrum antibiotic because we have culture, and we take into consideration patient characteristic, like for example allergy. If they are allergic to beta-lactams, we should avoid them. We take also in consideration PO versus IV. If the patient can tolerate PO or not, we prefer it, and so on. So this is only to show you an example.